All right. So we're going to get started because there is a lot of awesome content, and I want to make sure we get to all of it. I'm Aisha Davis. I am a hospitalist and one of the associate directors of the pediatric residency program, and I'm actually here to introduce our introducer. So we're pleased to welcome Dr. Renee Jenkins. She's come from right across the reservoir at Howard University College of Medicine, and she's here to introduce our Grand Round speakers. She's here as a guest, not as a speaker, but I couldn't let the opportunity go by to tell you who she is. She's a professor and former chair of the Department of Pediatrics at Howard University College of Medicine, and I wanted to introduce her because she's been a trailblazer in so many ways. The list is long, but I'll just select a few. She submitted the adolescent health section to the iconic Nelson textbook of pediatrics, contributing to 2 editions. She was the first African-American president of the Society of Adolescent Medicine. She was elected to the prestigious Institute of Medicine. And in 2007, she was elected to serve as the first African-American president of the American Academy of Pediatrics. So she has had contributed quite a lot. So she's also been a mentor to both of our speakers, so she's here to introduce them tonight.
Good evening, everyone. It's the end of the day, so let's make sure we all have our energy up. Okay. I am so pleased to be invited to even listen to the presenters today because I know both of them fairly well. The first speaker, Hope Rhodes, is a graduate of Howard undergrad as well as medical school, and we knew very early on that she was a star and is demonstrating that in the work that she does now. She's assistant professor of pediatrics at George Washington University, and she is a staff pediatrician here within the Children's National Health System. But I think Hope, as a child advocate, because we're really talking about advocacy today when we talk about what the status of health is for children in the district, Hope is one of the people who I think does 2 things. She's on the ground, working in a clinical situation, assessing that, but she's also doing research around that work and asking the right questions. And it's important because that's the foundation of the evidence that we use when we go to advocate. We should be going with as much solid information as we can. And I think Hope is really steering her career in that direction. She is building skills. She, as you can see on her bio that was distributed, has graduated from the Master Teacher Leadership Development Program at GW, but she most recently got a Master's in Public Health at Johns Hopkins. And so she's honing those skills so that that work that she does can continue and really improve the status of child health. So we are going to be delighted to hear Hope really talk to us about some of the statistical information around child health in the District of Columbia. I'm going to introduce both speakers now, and then they're going to present back to back. Then we'll have remarks from Dr. Newman, and then we'll have questions. So going on to that, Renee Falusi, I did not know her as early in her career, but I knew her when she was a resident who was the district representative for the residents. And I saw her at one of the district meetings and say, bingo, there's a leader, okay? Even early on, we could tell. And she's had a really stellar leadership path so far within the American Academy of Pediatrics. She currently is on the Diversity and Inclusion Committee, but she also has been the chapter president of the District of Columbia chapter. And I see in her future more leadership opportunities within the Academy. But we are not the only ones that have recognized her leadership capability. She was honored this year as a under 40 leader in health award by the National Minority Quality Forum. And that is not on the bio that was given you, but I think that's really a really important opportunity. But I think both of our speakers are very much personified pediatric advocacy. And I'd like to just read a section of what the Academy really talks about around pediatricians being advocates. Pediatricians have long believed that they can play a powerful role in creating lasting and meaningful change for the patients they serve. In fact, the Academy was founded by pediatricians to help ensure that patient advocacy remains a priority for the profession. What makes the profession of pediatrics unique is its commitment to not only treat sick and injured children in the professional setting, but also to work systematically to change the environment that contributes to children's illnesses and injuries through preventive efforts. Through their advocacy efforts at the individual, community, state, or federal level, pediatricians can move from treating one patient at a time to being part of a broader network of advocates that works systematically. And I think our two speakers this evening will really demonstrate to you the passion for understanding it, not only in the office, but also in the community. So we'll start with Dr. Hope Rhodes.
All right, good evening, everybody. Excellent. So we have a big thing to accomplish this evening, and I just want to start off by saying that it's a pleasure to present alongside my former Chief Resident, Lon Ray. Thanks to Dr. Aisha Davis and Devesh Agarwal for the invitation alongside the residency program. And I also want to say thanks to the applicants for coming back for a second look or coming for an initial interview. And I hope that we all kind of learned something tonight throughout this particular talk. So we're tasked with kind of covering or reviewing the state of pediatric care or pediatric health in the District of Columbia, but we're going to really be focusing on some areas that are near and dear to our hearts. So I'm interested in mental health and reproductive health, and we're also going to be talking about immigrant health as well as advocacy and what we're doing in the primary care setting to kind of combat some of these things. So we have no relevant disclosures and no conflicts of interest to talk about. So this is one of my favorite historical African-American figures, Frederick Douglass. And for those of you who do not know, he is a product of the D.C., Maryland area. And our newest health center, CHP at Anacostia, is only moments away from the Frederick Douglass house. And he said that it's easier to build strong children than to repair broken men. And I think that that kind of goes along well with what our mission here at Children's is, which is to help kids grow up stronger. And we're doing that across the entire institution, and we're also focusing on that in the primary care setting. So my chair, who is here, Dr. Weissman, likes to talk about the city of D.C. as a tale of two cities. And even though there are pockets of wealth throughout the city and also pockets of poverty throughout the city, I think that there is no secret that there are concentrations of poverty in certain areas of the city, namely wards 7 and 8. And so if you look at this map of D.C., and for those of you who may not know, D.C. is divided into 8 wards, and the Anacostia River kind of sits right here and separates wards 7 and 8 from the other areas of the city. If you are a child growing up in these neighborhoods, you are 40 to 50% more likely to grow up in poverty than if you're growing up in other areas. And when we talk about the median household income, if you're a child growing up in wards 2 and 3, on average, your guardians will make something like $200,000 a year, as opposed to $25,000 to $30,000 a year. 30% of D.C. children actually live in poverty, again, higher if you're in Ward 7 and 8. Almost half live in with families who have no secure employment or no secure housing. 30% live in food insecure households, and 40% of our kids do not graduate from high school on time. And so the question is, you know, why are we talking about this if we are here to focus on child health? And I think the answer to that question is twofold. One is we now know that disparities in healthcare are really perpetuated by the social determinants of health. So it's not just about your access to care, it's not just about your family history, but it's also, you know, are you exposed to trauma? Are parents scared to allow their kids to go outside and play? What kind of schools are you growing up in? And then what kind of insurance do you have? Are you insured at all? So all of these things are very important when we talk about pediatric health care. And then the other factor that plays a key role is that you'll soon see that the distribution of some of these ailments that we're going to be highlighting tonight really follows the trend of poverty. So if we go back to this slide here, if you are a kid that's growing up in Ward 7 and 8, you have a higher chance of being obese. You have a higher chance of living in a food insecure area, being malnourished, having asthma, being a teen parent, having an STI, et cetera. So that's why it's important that we kind of highlight that. So I'm going to switch for just a second and talk about the Goldberg Center and who we are. So we have 6 primary care centers, and we also operate the mobile health program. And all of our centers are actually recognized as patient-centered medical homes, and I'll define that for you in just a second. But we are the largest primary care provider for children in the District of Columbia. So I like to think of a patient-centered medical home as a centralized place of care where the patient is actually at the center of that attention. And call me naive, but I think that that's the way that it should be, right? It's not really about what's best for the providers and the doctors. It's not really about what's best for the administrators, but it really is what do the patients and the families actually need. And we want to provide care that's accessible, comprehensive, family-centered, culturally effective, et cetera. And I like to give the example of the family of 4 that's led by a single mom who may be employed, and so she's got to make the decision for her 3 kids as to whether or not she's going to miss work and miss wages for the week of the month to bring her 3 kids into the center if she works a regular 9 to 5, or is she going to actually take her kids to the doctor? And we really don't like to make our families have to choose between the 2. So that's why we have to extend our hours and offer weekend hours and make sure that we are being accessible to our families. And so that's just one example. The other thing is providing coordinated care, especially for our families that have kids with many complex medical issues. It is very important that we do a good job of providing coordinated care, and we like to staff our centers so that we are able to do that. So we do have a presence down in Southeast DC, and we're expanding our presence there as well. So the newest site is the CHP Anacostia site, and our Martin Luther King and Good Hope Road clinics. We kind of outgrew our capacity there, and so the institution responded by allowing us to open up a new center at Anacostia, and we call it Anacostia by the big chair because there is literally a big chair that sits outside of this building. And then the other thing is the ARC, which if you're applying to the community health track, you probably have gone down to the ARC and seen what a beautiful facility it is, and we're expanding that facility as well. So even though we're going to be focusing on, again, areas that are near and dear to us, regardless of what your interests are, we can have something, there's work for everybody to do, so to speak. So if your thing is asthma, we've got asthma. If your thing is oral health, we've got initiatives in oral health. If you're interested in obesity, we've got areas of interest there that you can kind of tap into. But the thing is, there is a lot of work to kind of go around, and whatever your interests are, Goldberg Center is probably doing something in that area. So let's actually talk about reproductive health. And what we're going to do is highlight the rates of sexually transmitted infections. We'll talk about teen pregnancy, and then we'll talk about some of the things that we're doing in the Goldberg Center. So these are the rates of new cases of gonorrhea and chlamydia for patients who are under the age of 15. And so I think the point here that I want to make is that although the trends in DC are going in the right direction, which is we're going down, these solid dots here actually represent the national rates of gonorrhea and chlamydia. And you can see that for both, we are higher than the national average. So doing some great work, rates are coming down, but in this particular patient population under the age of 15, our rates are still higher than the national average. Same trend for our young people that are in the ages of 15 to 19, if you take a look at the rates of chlamydia, which is the green line here, and then you see where the national average is, there's a considerable gap as to the number of new cases of chlamydia for patients in this particular age bracket in comparison to the national average. And then for those who are 20 to 24, and we take care of kids up until they turn 22, so this is why this is important to us and included, the trends are kind of stagnant. So we're not really making as much improvement as in the other areas, but, our rates are either on target with the national new cases of gonorrhea and chlamydia, or we are actually not doing as well. So we're not really making a lot of headway in this particular age group. And then when we switch over and we talk about HIV, right, because for many of our parents, they contract HIV the same way that they do other STIs. The highest prevalence of HIV in the country is in DC. So we have a rate of 2.5%, and our HIV experts in the organization like to compare this to the national rates of HIV in Rwanda, which are about 3.1%. So still we have a lot of work to do. The young adult prevalence, and so again, we're taking a look right here, and if the epidemic level is 1%. For DC, you're age 20 to 29, the prevalence of HIV is 1.1%. So it's still considered epidemic level. And then these adults go on to, of course, have children. So those particular children of HIV positive patients are at higher risk of course, contracting HIV vertically. And in talking with or communicating with Dr. Kathy Ferrer, who's actually in the audience, just this past year, there have been 2 cases of vertically transmitted HIV. So again, work that still needs to be done. And then if you take a look at this map of the U.S., we are right here, and it's kind of small, but our rate 6.9 new cases for every 100,000 people, and this includes both adolescents as well as adults. And so our patients, because we're servicing them up until the age of 22, this includes patients that are still in our age range. So again, work that needs to be done. When you talk about teen pregnancy, the good thing is that the rates of teen pregnancy across the country are on the decline, which is excellent. And the rates of teen pregnancy in the district are also on the decline, which is good news. But our rates are still higher than the national average. And again, if you live in Ward 7 and 8, you have a double to triple the national average. You have a higher risk of being a teen parent. So if you go back, the rates of teen pregnancy nationally is 26.5, and you can see that for Ward 7 and 8 is 55 to 74. So that's double or triple the national average of teen pregnancy. And for STIs, for HIV, it's going to follow this same pattern. And then there still persists these disparities based upon which your racial or ethnic group happens to be. So even though for all racial and ethnic groups we're seeing a decline, which is really good news, if you are Hispanic or if you are non-Hispanic Black female in the U.S., you have a higher chance of being a teen parent than your other counterparts that are in other racial or ethnic groups. So we all know about the psychosocial and medical implications of being a teen parent, right? So high rates of high school dropouts, high rates of preterm birth, low birth weight, higher rates of behavioral disorders for those kids. Those children have a risk of themselves going on to be teen parents. And so there are a lot of social implications that are related to that. So what are we doing in the Goldberg Center? And we're going to be highlighting what's going on in the Generations Clinic. But one thing that's not up here is a presence in the high schools. And so recently our Adolescent Health Center secured 3 high schools, and we're going to be servicing as the school-based health centers for those particular high schools. And the good thing is that these 3 high schools will then become a part of our medical home. So in the event that young people get their care in high school, which is, to some degree normal, if those high schools are closed for whatever reason, they can then pop into our health centers and receive the care that they need there. We'll have copies of their medical records, et cetera. So it will be almost seamless, which is great. So this is hot off the press, the Generations program, which is a teen top program where we provide medical care for not only adolescent parents and their children, but we also provide intense case management services, reproductive health services, et cetera. This is now being recognized by the Department of Health and Human Services as an evidence-based teen pregnancy program, which means that not only has it been implemented, but it has been rigorously evaluated and now stands the task of potentially being replicated across the country, which is great. And the one thing that I like to highlight about this program is not only do we provide all of these great services, but there's also a fatherhood program that's run by the gentleman at the bottom, Dr. Henry Prempe. And we know that the needs of teen fathers kind of differs from the needs of teen mothers. And so it's great that we have something in place to kind of capture the father's needs as well. And so what are some of these outcomes that we're seeing with the Generations program? One of our goals with Generations is to reduce the risk of rapid repeat pregnancy or repeat pregnancy period for these teens. And for Generations patients, 8% of our patients kind of go on to have another unintended pregnancy. And you see that that's lower than the national average and also lower than the average in the District of Columbia. The other thing is that we have higher rates of contraceptive use. So our teen parents are 3 times more likely to be on some type of birth control 12 months postpartum in comparison to their counterparts, which are teen parents that are not enrolled in Generations. And then there's a higher rate of uptake for long-acting reversible contraceptives, namely Nexplanon and intrauterine devices, which has been shown to be very effective methods of birth control. So some of you who had your public health hats on may be saying, you know, you're kind of downstream a little bit talking about trying to prevent a teen parent from having another child. And so why don't we go upstream to try to prevent that adolescent from having their first unintended pregnancy? And so I'm glad that you're thinking about that. So we have a couple of projects that are in place to help address that. And we have many things going on in the Goldberg Center, but these are just a couple of examples. So one is Project Later, and this is a project that was implemented by Chris Schmitz, who actually runs our Generations program. And so it's a multi-pronged approach in order to reduce the rates of unintended pregnancy, that initial unintended pregnancy. And so what she wanted to do was equip our primary care providers with the capability of placing Nexplanon. So Nexplanon is something that is usually placed by OBGYNs, but we are very innovative in that we have 20 primary care doctors that are in the community, in addition to our adolescent health center docs, who can actually place Nexplanon, which is great. So for our patients who express interest in this, we don't have to necessarily transfer them or refer them out. We can actually do that right in-house. Reproductive health clinics, and this is a shameless plug that we're having a reproductive health clinic tomorrow at COMP. So if you have a patient who's interested in getting on birth control or learning more about birth control, definitely come and talk to me and we can give you some information about that. But the young patients, they don't need an appointment. They pretty much just go into these reproductive health clinics. They get about 30 minutes of information about the various forms of birth control. And then if they decide that they want to get started on something, they can just hang out and get started on something. They can also get STI screening and beta screens done as well. And then we're also, again, in the school system doing counseling and providing education to peer counselors that then go out to other schools and actually do peer counseling about reproductive health methods, which is very, very effective. The other thing is Title X funding, and so Title X is the federal government's family planning service, and so we've secured some federal dollars in order to do 2 things down in Anacostia. One is to expand access to on-site medication, so purchasing reproductive health medications and having them right in clinic. And then the other thing is around case management services, which is what I'm really excited about, because usually the way that it goes is a teenager comes in, she gets counseled about various forms of birth control, and then because the amount of information is overwhelming, she pretty much, you know, doesn't make a decision and she leaves, and then 2 to 3 months later she comes back because she's missed her period or she's done her pregnancy test at home, or we're getting notified from the emergency department that, you know, your patient has been in here and she's got a positive data. And so then we're kind of, again, downstream a little bit. What this case management service does, it actually reaches out to that particular patient and provides additional information or counseling, answering any questions that she may have, and then we can get that patient actually scheduled so that she can get started on some method of birth control. So again, the take-home point is that health disparities in adolescence, STIs, and pregnancy still persist in DC. However, there is work to be done, and we're actively working on that. And if you're interested in getting involved, if you're a resident or a future resident, definitely there is work that you can do there. So we're going to switch gears a little bit and talk about child and adolescent mental health, and then I'll turn it over to Lonray. But 1 in 5 children across the country actually experience mental health problems, and less than half of these children actually get into effective management in a timely manner, and the issues are very broad. So mood disorders, anxiety disorders, ADHD, you name it, our kids are actually experiencing it. And the trends in DC actually follow national trends, and that 17% of parents say that their child at one point or another has been diagnosed with 1 or more developmental or emotional or behavioral disorder. And you can see the rates there for adolescents. And I don't have to read that, but I think the point that I want to make is that a lot of these mental health disorders kids start showing symptoms quite early. So for anxiety disorders, on average, by 6 years of age, kids are showing signs and symptoms of that. For behavioral disorders, by age 11, if your child has, goes on to have a behavioral disorder, they're probably demonstrating signs and symptoms at that particular age. Mood disorders, 13, and of course, substance use disorder is going to be a little bit later. Average wait times for kids to actually get into effective treatment, 8 to 10 years. From the onset of symptoms until somebody recognizes it and they actually get into effective management, it takes quite some time. And unfortunately, far too many of our kids are being picked up with mental health disorders when it's a crisis. So if we're suicidal, we're showing signs of, homicidal ideation, we are getting kicked out of school, whatever it happens to be, and then the, flag goes up that, oh, maybe this kid has a mental health disorder. But as you can see, several of these kids are demonstrating signs and symptoms much earlier. There is a national shortage of pediatric mental health specialists, and I don't think that's a secret. And recently, information shows that we only in the U.S. have about 45% of the pediatric mental health care providers that we actually need to meet the mental health needs of the patients that we serve. And of course, there's a shortage that is worse in rural areas and low-income areas. And so this is an older map of DC again, but the one thing that I want to highlight, if you can see it, is that the red dots actually represent standalone pediatric psychiatry practices. And the blue dots represent the mental health services for kids that are actually in the school system. And so if, again, Ward 7 and 8 is right here, you can see that the majority of dots are going to be the blue dots. So a lot of the mental health services for kids in Ward 7 and 8 are going to be in the school-based centers. And so that's okay, but usually those are going to be your social workers, your case managers, your counselors that have some degree of ability to kind of manage mental health needs, but it's not going to be your psychiatrists and your psychologists. But then when you go uptown, you'll see that there are far more red dots in this particular area here, demonstrating that if you live outside of Ward 7 and 8, you have a higher chance of actually getting to effective management. But the question is, where is the majority, or where are the majority of patients that actually have mental health disorders and pediatrics? Although they're all over the city, the majority are going to be in Wards 7 and 8. So we like to think of mental health in DC as the 20/20 problem. If you've got 100 kids, 20 of those kids are going to go on to have some type of mental health disorder. And of those 20, only 20% of those kids actually get into effective mental health management in a timely fashion. So again, there's work to be done. What happens when these disorders are not addressed? Obviously, kids that have mental health disorders that are unaddressed go on to be adults that have mental health disorders that are progressive. High school dropout rate, child pregnancy, unstable employment, substance use, and then involvement in the justice system. So again, talking about going upstream, we're doing a lot of different things, one of which is not up here, is routine mental health screenings that have now been implemented across our health centers. So annually, when kids come in for their routine checkups, we're not just doing this cursory surveillance, checking in, how's your kid doing emotionally, et cetera, but we're using a standardized tool in order to kind of screen these kids in some type of standardized way to kind of capture it, or at least start the conversation with the parents that something may be going on. Social workers in the health centers, co-location of mental health services like psychiatrists and psychologists in our health centers, and then for those kids who have complex medical needs, this kind of complex care program that helps to facilitate care coordination for them as well. So in 2013, the DC Department of Healthcare Finance mandated that patients that were enrolled in Medicaid actually have a routine mental health screen, again, a standardized mental health screen. And so Children's National actually led the way in trying to help facilitate and implement this across the city. So it included 15 pediatric practices and 130 pediatricians. And so there were 2 rounds of quality improvement initiatives that actually took place, and this is information from the first round of quality improvement. And you can see that the blue bars represent what we were doing before this project, and then these orange bars actually represent what happened after we implemented. So for these practices, 75% of the practices actually were completing standardized mental health screens. And then when we talk about about sustainability, you want to make sure that you can bill and get reimbursed for those things. And so practices were also billing and, for these mental health screens as well, which is quite important. So there's a whole bear care, which, again, our institution is responding to the fact that pediatricians were saying, okay, great, we can do as many mental health screens as we would like to, but if we don't have a place to send these kids once we have a positive screen, are we really making an impact? And so, again, the institution responded and has placed psychiatrists in the primary care practices. So we can curbside them unofficially to say, I've got this kid, I want to do this with the medication, what do you think about that? Or if there's a kid in crisis and they're in the office, we can definitely get them to come in to see that particular patient. And then the other thing is providing kind of standard care until we get them into a long-term mental health clinic, which is very helpful. And then the final slide is about going upstream a little bit, because we know that the experiences of kids when they're younger definitely impact their mental health as young adults and adults. And so we're going to be piloting at CHP Anacostia and the ARC something called the Healthy Steps program, and that addresses the care, emotional well-being, development, et cetera, for kids that are much younger, ages 0 to 3. And if you recall, a lot of kids who go on to have mental health disorders are demonstrating these mental health disorders before they turn 14. So this is really a great place to start kind of screening and implementing and providing some care around that, in addition to the care that we already do. And so the unique thing about this program is that there's a Healthy Steps specialist, and this is Dr. Stacy Hodgkinson, who is one of our psychologists here, and Dr. Dominique Squealy, who is from Georgetown, will be doing side-by-side type of models where they're in the visit with the pediatrician to kind of pick up on some things that maybe is going on with the parent, or pick up on some developmental issues that may be going on with the child, and actually providing some additional care as opposed to us simply referring out. They'll be able to kind of take care of some of these things in-house, which is very effective. So more to come with that. So there's a shortage in mental health providers. A lot of mental health conditions are popping up in early childhood, and we're trying to do our best to combat that. And the medical home actually, in some ways, at Children's is filling the gap for what's needed in mental health. So then I'll turn it over to Lon Ray.
Great, thank you so much, Hope, and Dr. Jenkins, thank you so much for that wonderful introduction. So switching gears, I'll be talking about immigrant health and then about what we're doing in terms of advocacy here at Children's National. My interest in immigrant health began with my first job after residency. So after leaving Children's, I went to work with Community Clinic, which is an FQHC just across the border of DC and Maryland, in Cumberland Park, Maryland, where there is a large and growing Salvadoran population. I got to really know that community very well, worked there for about 7 years and came back and have been really working within Goldberg Center and within CHI, looking at some of the work we can do with our immigrant population. I'll also talk a little bit about the DC AAP. Those of you who know me, you know that I cannot stand in front of a group of people and not talk about the AAP. So you'll hear a little bit about some of the work we're doing with that too. So pop quiz. It's a brief survey of the audience. Those of you who know DC or don't know DC, where do you think the majority of our immigrant population comes from? What countries do you see immigrants from? El Salvador, Ethiopia, Nigeria, Mexico. Great, so we got most of those. So the largest population comes from Ethiopia. About 75,000 Ethiopian immigrants live in DC, and that's actually a conservative estimate. There's some estimates of up to 200,000 if you go a little bit further into Maryland, into Virginia. Second largest comes from El Salvador, so about 18,000 in DC proper. When you go again into the suburbs of Maryland, it's double or triple that number. About 20,000 from Nigeria, including Prince George's County and Montgomery County. About 5,000 from China, and about 3,000 from the UK. So just another snapshot, about 1 in 7 people in DC are foreign-born, and about a third of those naturalized citizens. About 3% of the immigrant population in DC is undocumented. The majority of the Hispanic immigrants come from El Salvador, as you mentioned, Mexico, someone mentioned, also from the Dominican Republic. The DC census last year showed that we have about 670,000 residents. In 2010, 9% of those were Hispanic or Latino. That has grown to over 10%. Most of them living in Ward 1, which is where Adams Morgan Clinic is, and Ward 5, which borders with Maryland, which also shares a lot of our immigrant population. So I'm going to focus mostly on our Hispanic and Latino families, in particular the needs of the unaccompanied minors that we see. Again, not saying that other immigrant groups are less important, but this is a growing group and has very special needs. The Washington Post wrote an article about unaccompanied minors coming across the border a couple of years ago with the surge that occurred in 2013, 2014. And actually one of the patients pictured here was a patient of mine when I was at CCI. And I like the quote that they included here, which is that these children have crossed the U.S. border, but their journey is far from over. So just to define who we're talking about, an unaccompanied minor is a child under the age of 18 who crossed the border into the United States without an adult who is there to care for them. So they may have come with an adult who their family back home or here had paid to get them across the border, but that's not someone who is actually charged with their care. So looking at apprehension, so these are the kids who were stopped at the border at Texas and apprehended by the authorities, looking at country of nationality. So the darker blue line here at the bottom is Mexico, which has basically stayed stable over time. The other countries in Central America are pictured here, El Salvador, Guatemala, and Honduras, which over the last couple of years has really spiked. And we'll talk a little bit about why some of that might be happening, where now you have almost equal numbers from those 4 countries. So how do they get here? So, we're looking at Guatemala and further down, sort of Honduras and El Salvador. Conceivably, kids coming from this area need to get through Mexico in order to get into the United States. Once they reach the border of Mexico here, some of you may have heard about the beast or the train of death, El Tren de Muerte, where people will literally climb on top of a cargo train. There are these networks that cross through Mexico to actually get into the United States. So you can imagine this is not a stable surface. Risk of infections, risk of trauma, physical and emotional. We'll talk a little about those also. Looking at, again, who is apprehended at the border. Before we go into the numbers, I want to make a point that the numbers here are not necessarily the numbers of who are entering the United States. So it's estimated that for every 1 person who crosses the border and is apprehended by the authorities, another 2 or 3 maybe make it across the border. So these are, again, underestimates. What strikes me here is the trend. I think in the media when we hear about sort of illegal immigrants or undocumented persons coming across the border, we're literally seeing pictures of grown men crossing over the river or crossing over a fence. But who is really coming over? We're talking about family units over time, from 14,000 to over 77,000 FY16. Children, number of children, nearly doubling over the last 3 years. And actual individuals, that number is actually dropping. Overall, immigration in some places has actually become stagnant, but looking again at who's increasing, I think this is what I find to be really striking. So what happens then when they get to the border, if they're apprehended by Customs and Border Control, and if it's a child, they have about 72 hours in that detention center to identify the child and then do just a very cursory health screening. They get vaccines, they get PPD, some empiric treatment for things like scabies or other skin disorders, and then they initiate removal proceedings. So it's not a pre-ride, right? So once they get in, the reason that they're not sort of turned away at the border and returned to Mexico, for example, is if the child is originally from El Salvador, rather than returning them through Mexico and into El Salvador, they start deportation proceedings. So they actually go through a legal process. If they're unaccompanied, then they are actually transferred to the custody of HHS, to the OOR, the Office of Refugee Resettlement, provided with shelter care, and the options are explored. So if they have a family member in the U.S. with whom they're reuniting, that family member may choose to fund that child's travel to them, again, while they're waiting for the deportation proceedings. If not, they may end up in a shelter, either somewhere near the border or there's shelters throughout the United States. And there's some individuals or families who've also offered to be foster families for these children while they're waiting for deportation proceedings. So looking at where they end up, so this is the top 10 in terms of the states and where unaccompanied minors are released to sponsors, and sponsors, again, being either the foster parents or their family members with whom they're reuniting. So you'll see that Maryland and Virginia are in the top 10. And although California, Florida, and Texas, New York receive a larger number in terms of gross numbers of unaccompanied minors. When you look at per capita, Maryland, our neighbor to the north, actually has the highest number per capita of sponsors, with those numbers being largest in Langley-Tacoma Park, again, right across the border from us, and with from where we have a lot of our patients. So I just want to put a face to this issue with a couple of patients who I personally cared for in my last position at community clinic. One named Maria, 12-year-old who I saw with her mother for her first visit. She was born in El Salvador. When Maria was 4, her mother left and came to the U.S., left Maria with her grandmother. The mother has since remarried in the U.S. and has a young son, started a new family. Maria crossed the border from Mexico into Texas with a small group of teenagers about 3 months ago. And then during the course of the visit, she tells you that in one house where they stopped for supplies, an older man gave her a pill that made her feel dizzy. She doesn't recall what happened the rest of that day. She also tells you that she's uncomfortable with the way that her new stepfather looks at her. And then there's Daniel, who's 17. He's here with his mom, who's having some difficult behavior at school. Previously had been a good boy, she says, at school, had above average grades, had plans to go to college. But in the last few months, the teachers have noticed that he's become more distracted, more angry. She feels that he picks fights with her and his father, often chooses to be sort of separated, eating dinner in his bedroom. And then she confides in you that although Daniel was born in the U.S., she and her husband are undocumented. They fear that they'll be at risk if he applies for college and looks for federal aid. Daniel also tells you that he fears that his parents will be deported one day. So these are real people that we're talking about, and that sort of, I think, flows into what some of the health challenges that we're seeing in our clinics. Some of which you can sort of expect mental health disorders, so stress, PTSD, depression and grief, family separation, either actual real family separation because a parent may have been deported, or the fear of family separation, like with the patient Daniel that I mentioned, and also reunification issues. So, Maria, who hasn't seen her grandmother or hasn't seen her mother in 8 years, reuniting with her in really a new family that she doesn't know. Assault and rape, which we were very much concerned about with that first patient that I mentioned, lower immunization rates, concerns for infections, poor asthma control, developmental delays, anemia, a lot of this kind of wrapping up with issues of poverty in their home countries. And then there are barriers to achieving optimal health. Again, poverty, as I mentioned, lack of health care coverage. In a minute, I'll talk about what some of our immigrant families are eligible for or not eligible for in terms of health care coverage, language and communication issues, literacy, health literacy, and literacy not just even in English, but even in their own written language. We're seeing a lot of barriers with that. Lower educational achievement, and this issue of fear that is real, I'm probably speaking to the choir, but I know folks are aware of increase in fear and bullying and that sort of thing within our communities as immigrant families, and the fear that is perceived. So Daniel's a U.S. citizen. Certainly he can apply for financial aid, and his parents should not have to feel the fear of getting into a system from that, but there is a perception of getting into any sort of system, whether it's governmental or not, from some of our families. But it's not all bleak. There's some protective factors. Lots of family support, community and cultural identity is very much protective in these families and these children that we see. The vast majority of children who have foreign-born parents have a parent who works, and most of them have two parents who work. So what do they actually have healthcare? What are they actually eligible for in terms of healthcare access? If you're a lawfully present immigrant, you are eligible for Medicaid, for CHIP, for ACA benefits. There may be a 5-year wait. DC, Virginia, and Maryland do not have a 5-year wait for children and pregnant women, but other states do. If you get a green card, for example, you may have to wait five years in other states before you can be eligible for Medicaid. They can use state exchanges. Refugees are also eligible for benefits. To be clear, though, DACA is the Deferred Action for Childhood Arrivals that you may have heard about in the news. Those individuals are not actually given true lawful presence, so they're not eligible for any federal benefits. If you're an undocumented immigrant, on the federal level, you may be eligible for emergency Medicaid for deliveries, for pregnancy. There's certain protected statuses that are eligible for some of the federal benefits, but generally undocumented immigrants are not eligible. Within DC, they're fortunate to have the Healthcare Alliance and the Immigrant Children's Program that provides Medicaid-like services. So for kids, it's very similar to Medicaid. For adults, there is not the coverage, though, for behavioral health, but for primary care there is. Maryland, Montgomery County has a Care for Kids program, not quite as robust as DC's program, but fairly similar. For right now, Prince George's County does not have any services. The asterisk there is that I've heard that there have been discussions about programs starting, but as of now, there's not, in Virginia currently does not. So where do these families go to? Well, one, they come to us. We have community health centers in the community. They're federally qualified health centers like CCI that I mentioned, Unity Healthcare in the area. Emergency departments, which is not a sustainable source of primary care, as those of you who were here at prep rounds this afternoon, we talked about that. Safety net hospitals also accept these patients. There's certainly legal issues affecting immigrant children, family law issues, immigrant status, of course, deportation cases, where you've had children as young as 4 years old defending themselves in court, in immigration court, because the family either was not able to afford a lawyer or it didn't quite have the resources with which to find a lawyer. Public benefits, this issue of, if the child is a citizen, the parent's not a citizen, what are some of the benefits that they may or may not be eligible for? School enrollment, so every child does have the right to be enrolled in school. There have been communities that have tried to block the entrance of undocumented children into public schools, which is not legal, and that has, most of those have been struck down, but folks should know that they do have the right. Statutory rape is a definite issue too, which in DC, if they're 15 or younger, and that is, even if it's consensual, that is considered statutory rape. So we're seeing lots of cases around that and lots of needs for referrals to our Child and Adolescent Protective Service and to mental health. So what are we doing about this? So quite a lot, I'm happy to say. So we've done quite a bit of provider education, largely within the DC AAP chapter. About 2 years ago, we had Fernando Mendoza, who is an expert on immigrant health from Stanford, come as a visiting lecturer. July of that year, following Dr. Mendoza's visit, the DC chapter created an interdisciplinary immigrant health committee that included physicians, of course, but also individuals from the school system. We had a lawyer from Children's Law Center who became a permanent fixture, actually, in our meetings, which was wonderful. And then since then, we've had ongoing collaborations. We received an AAP Healthy People 2020 grant to create a toolkit that's online, currently in beta testing. Earlier this month, we held an advocacy training for providers on immigrant legal rights, and then spring of next year, we received a grant to do an immigrant mental health seminar, so you'll all be hearing about that. Here's just a screenshot of our toolkit. There's the website. We'd love for you all to try it out, give us some feedback. Like I said, it's still in testing, so still some tweaks happening. And then just on the ground with patient and family support, in Adams Morgan, March of this year, they held a Familias Reunidas seminar, so Families Reunited seminar, in which families in which a child recently reunited with the family after being separated for however many years. They came together, led by a social worker who's bilingual. There's an amazing curriculum that was actually created by Fairfax County Public Schools that they went through in terms of helping the family know how to communicate around these very sensitive issues. Lots of advocacy campaigns with National AAP. We have future collaborations. We're applying for a grant right now to help families within the primary care centers screen for legal needs and be able to connect them with legal resources, for example, and other projects happening. So what can you do? You can advocate on all these levels, so patient level, local level, national level. Ask and talk to families about what needs they have and referring as needed and really utilizing the medical home. No one expects one provider to be able to do all of this. Letters to the editor, joining DC AAP chapter, and we also have some ongoing collaborations with the Mayor's Office of Latino Affairs. They also do provide some grant support. Then nationally, we all will get these slides, so you kind of click around and look at some of these resources. So it's a nice segue, I think, into advocacy for our final topic for tonight. This is my opportunity to do some CHI propaganda, as I like to say. So CHI is the Childhood Advocacy Institute here at Children's. So we are the first hospital-based center in the country focused on developing outreach programs and championing policies that improve the health of children. So we're a team of pediatricians, of lawyers, of public health and data experts, and CHI has been in existence in Children's for over 30 years. Pictured here is Tanya Kinlow, and also here in the front row, who leads this effort. So what we do is we really carry on the advocacy mission of Children's National, doing all these things. So looking at policies, new ideas and ways to really do some population health, data and evidence surrounding that. And then I'll talk a little bit, especially since I know we have some applicants in the audience, about some of the education we're doing around advocacy and how you can get involved. So what's our approach? We have a four-pronged approach. First with community affairs, led here by Desiree De La Torre and Dr. Danielle Dooley. They're leading the Community Health Improvement Plan, which is based on a needs assessment that we did in conjunction with other hospitals and community health centers in DC. So there's a copy of this in the back, and I have one up here for anyone who'd like to flip through. Very extensive, full of lots of great data of the needs of the community and what we as a hospital can do to improve those needs. Municipal and regional affairs, Dr. Lee Beers and myself. A lot of you may have heard of DC MAP, so that was also came out of CHI. So DC MAP is the DC Mental Health Access and Pediatric Primary Care. So for providers, if you don't know about this, you need to know about this, not just for primary care, but any provider. If you're seeing a patient for whom you need some mental health consultation, either for yourself to help figure out, say, medication dosing, for example, or if you have to refer the patient out, this is a free program. Some brochures are in the back, and I have one up here with the number to call. This is just an amazing project that grew out of some of the work that Hope mentioned before. The Child Health Data Lab, run by Dr. Chaya Merrill. If you've not gone to the dchealthmatters.org website, please do. You'll see community dashboards with some really great health indicators. If you're writing grants, if you're doing any sort of research, this is a great website with lots of live, culled data from not just from children, but from DC in general. And I think a lot of you are probably more familiar with what CHI does in terms of government affairs, so a lot of legal advocacy that we do. These are 3 lawyers on staff who do advocacy in Virginia and Maryland with local DC government and on the federal level, and we've done a lot of great work, and we're all sort of integrated together. So a couple of really quick success stories. So Dr. Hemant Sharma, which some of you may know, is an allergist here. So he realized that kids can have allergic reactions in schools due to food allergies or other environmental allergies, but there weren't EpiPens available in schools. So Dr. Sharma works with Bill Quirk, one of the lawyers that I mentioned, to prepare testimony for the DC Council to pass a law to have EpiPens in schools, and now it's been law. So there are EpiPens in all schools in DC, so that kids, even if they don't already have an allergy identified, will have the EpiPen there available as a life-saving measure. And I mentioned this already, sort of the DC MAP, so starting from a Children's Law Center report about the needs of mental health in children in DC. Also, last success story here. So Children's has been one of the nation's leading hospitals in terms of pediatric research funding, and we're sort of, outgrowing our laboratory space here. So our government affairs team really works well with federal and local government to secure space in the Walter Reed Army Center space that closed in 2011. So we'll have very soon some really state-of-the-art space there. With education, we're doing quite a lot with medical students, mostly lectures and rotations. Residents, we have intern advocacy day that I'll mention in a second. We have a CHI rotation for community health check residents in the CHAP pathway, which is the Child Health Advocacy and Policy pathway for any residents. And GAP fellows also do rotations with us. And for faculty, we've gotten a lot of interest in terms of population health and advocacy training, so we're working on curricula and needs assessments on that. Quick plug for Intern Advocacy Day. This is one of few advocacy opportunities that are like universal and required for all of our residents here. We have tons of electives and tons of opportunities, but this is one that that all are required to do this. So they spend a day at the Capital Area Food Bank, which has just been a wonderful partner for us. They spend the morning actually volunteering, giving back to the community, packing boxes and learning what a food bank is versus a food pantry and the kind of work they do in the community. In the afternoon, they do this innovative poverty simulator called Face Hunger that's run by one of the food bank employees. Here's a picture from one of the groups that went. So that is also then followed by a senior resident or faculty debrief. Any faculty, fellows, senior residents, if you're interested in being one of the facilitators for the day, come and find me, or I'll come and find you. We've had 4 groups go so far, all of which have given us really good feedback. And we find that the larger the group is, first, the more robust the Face plant-based hunger stimulation is. But also, secondly, interns, as we've gotten feedback, really like hearing from people other than those who they're normally used to seeing, you know, sort of their usual faculty. So we're trying to be as interdisciplinary as possible. So take-home points. So what can you do to get involved with CHI? One, learning and teaching, join Immigrant Advocacy Day. You can become a chat pathway mentor. Testifying. If you are testifying on behalf of children, please reach out to our government affairs team so that we can all kind of make sure, not just that we're all on the same page, but also they have lots of data and lots of great institutional knowledge. And linking also with community organizations. If you're, again, looking for grants, that sort of thing, we can be a great resource for that. And then sharing what you're doing in your clinics. We do have a community benefit brochure that CHI keeps up every year of all the wonderful things that children's employees are doing in the community. So please let us know so we can be sure to advertise that. Acknowledge your population health efforts. Applicants. All of the things that you heard this evening are things that you can be involved in when you become a resident here. I actually don't know who are our applicants that are here tonight. If you can raise your hand for me. So everything here, yeah. So we love having trainees involved in our work within CHI and all the work that Hope mentioned. So quick thank you to all these folks. Dr. Renee Jenkins, so wonderful to have you here. It's an honor to have you introduce us. Dr. Aisha Davis, who put a lot of work into putting this evening together, along with the rest of the residency program leadership, including Dr. Agrawal. Rachel Sarnacki, where did Rachel go? Did a great job in sort of whipping us all into shape for this evening. And then Christine Smith, Kathy Farrar, Mark Weissman, Daniel Dooling, Desiree De La Torre, who all contributed to the presentation. So I apologize that we've run right up until 6 p.m., but please, I'd like to introduce first Dr. Kurt Newman, who is the CEO of Children's National. So if you all can stay a few minutes at least to hear his remarks, and then we'll stay here for questions for anyone who can stay for questions. If you have to leave after that, we completely understand. Dr. Newman.
Thank you, Landre and Hope. What a spectacular set of presentations you two gave. Renee was absolutely right. You were, whoever met you first knew that you were stars and leaders, and I think that's one of the great things about Children's National is the incubation and the mentorship that brings people along and rise through the organization. I just did want to say it's just wonderful to have Renee here. If you didn't know that, I don't know that she would want to be called an icon, but she is an icon of pediatrics. You don't get to be president of the American Academy. I mean, that's the whole thing. The American Academy of Pediatrics, if you're not just a superstar, and she's somebody that all of us here in Washington are so proud of because she's just been such a leader and such a partner at Howard, and then with the interdisciplinary research efforts with Howard, Children's National, and Johns Hopkins around disparities in care. It's just, she's just a great leader and a role model for all of us. And, you know, I'm not just the CEO, but I'm a card-carrying member of the American Academy of Pediatrics, so I'm very proud of that, and was head of the surgery section. So for those of you that don't know, because there are a lot of applicants here, I did my fellowship here, so I was a trainee here, and that was a long time ago. But, you know, I came here thinking, well, I'll be here for 2 years, learn pediatric surgery, and then build a career somewhere else. And I tell you, I just fell in love with it. And I fell in love with Children's. I fell in love with Washington, D.C. And actually, truth be told, I fell in love with my wife here, too. So, you know, you're not going to get anything bad out of me. I drank the Kool-Aid and worked my way up the food chain and have made so many friends and practiced medicine and here alongside. And many of the folks are here today, the faculty that are here that I grew up with, some of our leaders looking out in the audience. If I name one, I'm going to miss all the others, but you'll meet them at the reception. But Dr. Teach, our chair of pediatrics. I saw Dr. Kine somewhere, assistant dean at George Washington. Roger Packer, our senior vice president for neurosciences. Tanya Kinlow was mentioned, but I would like you to stand, Tanya, because they didn't see you down there. Who's head of government and community affairs. So it's Mark Weissman, also I see there, and Mary, our big education czar. Is that what you are? Czarina. Tom Silver, another icon, adolescent medicine here in the front row, and Duresh Agarwal, then our head of dermatology, our head of hearing and speech. There's just, what is it, too numerous to count, and then, but it's great that you're here. It's a community. And I hope you get that feeling. We're a community here. We have values. We had a retreat about our values today. And you know what was, it was interesting, the top value that our leadership felt that they wanted to embrace and promote was around diversity. And I just thought that was just really, at this time too, to think about that, to put that out front, to embrace our strength and diversity and what we are, how we feel about ourselves as a community. So those of you that are looking at Children's National, you'd probably go to a lot of other children's hospitals and programs, and everybody's proud of where they are with their specialty care and their U.S. News and World Report and Leapfrog and Magnet, and we're all of that, and our research institute. But maybe what you don't see sometimes is young faculty like this, leaders that are talking about real problems of our children are facing. Over half the children in Washington, D.C. live on the other side of the other river, the Anacostia. And you see, so if you're the kind of person that wants to tackle that, this is the place to come. We've got the great fellowships and specialty training, and you'll get, but if you also want that extra edge, if you want to have a place to make an impact, what better place to do that than in the nation's capital? And that's what draws a lot of us here. It's a great place to make an impact, to really, there's big problems here, but if we can do that here, and we have the leaders that you've heard from, they found their calling here. And that's, I think, what's special about Children's National, that we put, these things just don't happen. And I heard Hope and Lonray say it a couple times, the institution decided. There's no real institution. The institution is people. So it's our board, our donors, our doctors, our nurses. We decide what to do. And those are our priorities. So we're doubling down and just cut the ribbon yesterday on our new clinic at the Big Chair. We're tripling the size over at the ARC. We've just today, I'm proud, and this is hot off the press, signed our contract with the District of Columbia for the school nurse program to keep that going. Dr. Cora Bramble was not here. And school health is such a big part of what we do here in Washington, D.C., and also in Prince George's County now. So lots of big stuff, big ideas, a great place, and it's a lot of fun. Washington, D.C., I think it's probably now on those, what do you call them, those polls, and do we talk about polls or whatever they are these days? Surveys. Sure, thank you. Those surveys, it's one of the hottest, greatest places to live, and there's so much to do when you get a little time off. So I'm sure you'll have chances to talk about that up at the reception, but we are honored that you would take extra time to come here and kick the tires, think about spending 3 years with us as a resident, and it's if I can provide any additional information or insight, I'm happy to do that. Unfortunately, I can't be with you at the reception, but I know there'll be a lot of people there that'll be letting you. And we have a great softball team. I see two of our that's what you do. She may think she runs the comp clinic, but she's actually our cleanup batter. And I just say that because we have a lot of fun and we are a community, and we and there's Derek right there. That's great. He had kind of an off season this year, so not talking about you too much. Anyway, thank you all very much, and have a great rest of your visit.